Good evening, everybody. I'm really excited to welcome you all to this our webinar series, which is a joint collaborative effort by Haystack Analytics and Thyrocare. Our title for today's webinar is How to Catch the Notorious Ones in Tuberculosis. I would like to introduce Dr. Ema Chaudhary. Dr. Ema Chaudhary is a professor and HOD for TB and respiratory disease at Subharti Medical College. She is a reviewer in International Journal of Tropical Disease and Health, life member of ICS, IGCD, and the ERS journals, and has greater than 10 publications to her credit. So I welcome Dr. Ema Chaudhary and look forward to a really interesting talk.
Thank you, Dr. Aparna. Thank you, Dr. Anirvan, and thank you, Haystack Analytics, to let me talk on this. I actually was very happy when Dr. Aparna introduced all this to me. I felt I have been practicing for last 10 years, and I used to feel there were cases where I used to be stuck up. How to prove in front of the people that these are actually the notorious TB bacilli that we need to deal with. But because we had limited access to all these investigations, I couldn't do that. Now I'm able to prove it. Okay, so why I got this catchy topic for you all. This is the era where you need to go over the others by identifying what others are missing. And so this is how you catch the notorious ones. Who do we call as notorious? Sorry for that spelling error there. The students in the class are of two types. One who are notorious but are able to deceive you. You're not able to recognize them in the crowd. And the other type of students are the ones who you are able to recognize. Yes, this is the naughty one, but you are not able to discipline them. Similarly, in TB, we have the ones you are able to identify. They are sputum acid fast bacilli positive, but negative on the culture. Now, these can be either the dead bacilli or they can be the atypical mycobacteria. Or the other category of students that we thought of, they are MTB, right? But they are either CBNAT rifampicin sensitive or resistant. We are bothered about the ones who are CBNAT rifampicin sensitive but resistant to either isoniazid or pyrazinamide or ethambutol. Now, this is one of the cases where I thought early, this was a case as a 44-year male who presented with history of TB in past 2011. He took treatment for 8 months and he said it was DOTS. Now, if you start going to the history itself, this 8 months gives you the hint that he went from category 1 to category 2, right? So category 2, if he has been, there was some problem. Either he was positive after the intensive phase, there was some default in between, something was there. Then again, he had tuberculosis in 2019. He says he took treatment for 1 year from a private practitioner. Okay, so now if we see, there's a hint there. This patient was brought to my center with the right pneumothorax. On sputum examination, he was AFP positive. On CBNAT, he was R sensitive. Now, I went according to the government guidelines, and this fits into a first line sensitive category of patients. But how would you go about your treatment? We'll discuss in the discussions and the question answers that we have. Since I suspected there would be some resistance anywhere, everybody is able to see that out of the first line drugs, out of the 4 drugs, this guy is sensitive only to rifampicin, and the rest of the 3 drugs he is resistant to. So if you go by the government guidelines, you would have actually missed this case and treated this case as a first line sensitive patient, because we are just doing the AFP there and the rifampicin sensitivity by the CBNAT. So if you see on this slide by zooming up that he is rifampicin sensitive, but to other drugs, isoniazid, he's resistant to your ethambutol, he's resistant to ofloxacin, he's resistant to fluoroquinolone. So he actually fits into the pre-XDR category. If only rifampicin is not the catch there, right? So other than rifampicin, he goes into, if ideally we see, he goes into the pre-XDR category. So if I'm treating this patient with the first line drugs, 3 of them are actually not working. It's only just 1 which is working. So this patient would actually not improve, right? But if we do the genome sequencing earlier, we would find that we can use the other drugs which he's sensitive to and give the appropriate treatment that too in due course of time. It's not that we are wasting the time by giving first line and then we are seeing that he's not responding and then doing the further test. Okay, so this is another case. A 66 years male who presented to me with fever and hemoptysis. Again, there was the history actually clinches you where to use which test in a better form. So he had history of TB 16 years back, defaulted then. Then he again took ATT, which was X-ray based. There was no AFB stain done at that time, 4 years back, and he said he defaulted again. Now, this time when he came to our hospital, he had a AFB stain report which said he was positive outside. Now, how would you treat this patient? Most people would go with the CBNAT and with the government say that if this is R sensitive, and we would give the first line treatment. But again, to our utter surprise, because I was suspecting a multi-drug resistant kind of bacteria here, what I found was totally different. Next slide, please. This patient, to our utter surprise, came as one of the MOTT, the mycobacteria other than tuberculosis. Please focus on the Mycobacterium abscessus. Yeah. So there it is. If we are not able to identify such patients would keep on taking ATT, possibly they are not able to handle that drug, or possibly because of the liver side effects, they keep on leaving in between and they actually do not know what they are facing. And at times this would be the typical category. You will have AFP plus, but CBNAT not detecting the MTB. My experience with whole genome sequencing was significant, although I deal with a lot of patients and the number of AFP positive are much, much more in my clinic in a month. But over the last 2 months, for the limited amount of patients that we did, we had another patient, Mr. A.K. Mishra, who was actually pleural effusion with the underlying consolidation. So he did not have anything on the sputum. He did not have anything significant, AFB seen on the effusion sample, the pleural fluid sample. So started him on ATT, 6-9 standard drug treatment improved, but I saw the X-ray was showing the partial improvements. So I suspected something there. So this time I told him to go in. He had 3 pockets of loculated effusions lying, and I asked our radiologist to take a core biopsy from there so that I can actually send this for culture and the whole genome sequencing on it or the drug sensitivity on it. So finally, this patient today, when the report came, we found again he's one of the pre-XDRs, would have been missed earlier because in the initial samples, we could not do any testing there. So it is helpful for even those samples where you are not having just sputum. They are the other samples. This was a pleural biopsy sample. So these are my significant cases who have resulted. This Sanjo Devi is a patient who has already proven MDR from outside. She has taken the treatment also, and she has been told that now the sample has been sent. The medicines stopped as per the government protocols, and now she's just awaiting when would they say whether she is negative or not. She's not getting any answer for last 21 days. Meanwhile, in the same 21 days, we came in with a report which is sputum positive, and finally on the TGS, we found that she's multi-resistant, and I have a definite guidelines as to which drugs to choose from while treating her, rather than just leaving her with half medications and finally she turns out to be a total drug resistant or an extremely drug resistant kind of TB. So you have 2 ways. Either by your history and your workup, you suspect the notorious ones earlier, or you start thinking when they're not responding to treatment. So if you suspect earlier, you'll treat earlier. If you are thinking late, then you are losing a lot of time. So my crux lies there. If you feel they are affordable, I would actually, over the time, I wish I can bring up this study to the government so that they can incorporate into their government setup, that we don't lose the time in such cases. So better identify them early, treat them early rather than thinking later. But even if you are thinking later, you are still doing right comparative to the people who are not even thinking that these can be the notorious ones. And ultimately, we are losing such patients to the XXDRs or the XDRs form. Thank you.